So these were some important pharmacokinetic characteristics of the benzodiazepines. Now let's go ahead and understand the pharmacological actions of benzodiazepines. And as we know, we're calling them sedative hypnotics. So the first action, a very important action, is sedation and hypnosis. And when we discuss about hypnosis, we need to discuss a bit in detail about what happens to the sleep. Benzodiazepines decrease the latency of the sleep and they decrease the night awakenings. The patient could sleep for a longer period of time, so I say they increase the duration of sleep. What is the exact effect on the sleep architecture? Benzodiazepines are known to increase the stage 2 sleep, whereas they are known to decrease the stage 3, 4 and REM sleep. I'll say it again. Benzodiazepines are known to increase the stage 2 sleep and they are known to decrease the stage 3, 4 and REM sleep. Talking first about this REM, if you remember, we just said most of the sedative hypnotics decrease the REM sleep. That's what I'm saying. Benzodiazepines also decrease the REM sleep. So if you give them for a long period of time and then stop them, the patient is likely to get REM rebound. Right. These are the sedative hypnotic drugs, and we know stage 3 and 4 are the deep stages of sleep, are the slow wave sleep. So we really wanted an ideal sedative hypnotic to increase the duration of the stage 3 and 4 sleep. But unfortunately, this is not happening. The benzodiazepines are decreasing the stage 3 and 4 sleep and they are increasing the stage 2 sleep. But still, they have got less effect on the REM sleep as compared to barbiturates. Now, if you want to prove someone good, you need to prove how someone is better than the other person, than the counterpart. So, that's what I'm saying. Barbiturates were the age-old agents used for sedation and hypnosis. And now the barbiturates are outdated. We started using benzodiazepines because they are better than barbiturates. That's what I'm trying to say, how they are better. They have less effect on the rapid eye movement sleep as compared to the barbiturates. There is less distortion of sleep architecture as compared to barbiturates. They produce less hangover and more refreshing sleep as compared to barbiturates. Please don't misunderstand. Does it mean that after taking a benzodiazepine tablet, the patient is not going to have hangover? No. The patient is going to have hangover. But when I am saying less hangover, more refreshing sleep, I am always putting them together with barbiturates and trying to compare them and then say that they produce less hangover and more refreshing sleep. They decrease the movements and they decrease the night terrors which could happen during the sleep. And a very important effect most of the sedative hypnotics produce is anterograde amnesia. What's amnesia? You're going to forget the events which happened is amnesia. Which events? Anterograde. Going further. You took a tablet and after you took the tablet, it started producing a sedative hypnotic effect, and then whatever events happened after that, after you took the tablet, you are going to forget them, and that's called anterograde amnesia. So next morning you wake up, you remember you took a tablet at 9 p.m. last night, and after that you must have slept by around 9:30 or 9:45 p.m. But what happened during that half an hour, you're going to forget. That's called anterograde amnesia. It's not the specialty just of benzodiazepines, it also happens with barbiturates. Benzodiazepine action is very important because apart from this dose-dependent CNS depression and sedation hypnosis, they act on the limbic system and they produce a selective anxiolytic action. I'm again saying a selective anxiolytic action, and this is independent of the central nervous system depression. And this is why benzodiazepines are great. They have this anxiolytic effect. They also produce skeletal muscle relaxation. Do you remember your skeletal muscle relaxation chapter, which we did with autonomic nervous system? We classified the skeletal muscle relaxants into peripherally acting and centrally acting. And in the centrally acting, we mentioned benzodiazepines. So this is how they act. They act on the central nervous system and they relax the skeletal muscle. Important drugs which are used for this is clonazepam and diazepam. The next action is anticonvulsant action of the benzodiazepines, and they can stop the convulsions. Convulsions due to most of the causes can be stopped with the help of benzodiazepines. They increase the seizure threshold and this is why you can stop the convulsion. We'll come to the therapeutic uses based on this action later. As far as the cardiovascular system is concerned, they are central nervous system depressants, so they decrease the blood pressure and they also produce myocardial suppression and respiratory depression. That's very important to remember. They are known to decrease the nocturnal gastric hydrochloric acid secretion, and they are known to prevent distress ulcers. So these are some additional actions of benzodiazepines. Let's review them once again on the slide. On the first slide, it's sedation and hypnosis and all the details about the sleep. On the second slide is the selective anxiolytic action, skeletal muscle relaxation, anticonvulsant effect, myocardial suppression and fall in blood pressure, respiratory depression, and decreasing the nocturnal hydrochloric acid secretion. Let's have a look and try to compare them with barbiturates very rapidly. Benzodiazepines are better as compared to barbiturates. How? Benzodiazepines produce less distortion of sleep architecture, there's comparatively less hangover, there's less REM rebound on stoppage. The class began with the saying that most of the sedative hypnotics produce REM rebound. Benzodiazepines also do produce, but this REM rebound is less severe as compared to the barbiturates. Benzodiazepines have got a better therapeutic index as compared to barbiturates, meaning thereby they are comparatively safer. They have less cardiovascular and respiratory depression as compared to barbiturates. They have less tolerance and abuse liability as compared to barbiturates, and they also produce less enzyme induction, and this is why less amount of drug interactions. And very important thing is, when you get acute barbiturate overdose or toxicity, we don't have any antagonist. We don't have a competitive antagonist to displace barbiturates from the receptor sites. In case of benzodiazepines, it's different. We already said it, and I'm saying it for the revision purpose, is benzodiazepines have got a competitive antagonist. Name is flumazenil, and it's extremely useful in acute barbiturate poisoning. Let's come to the adverse effects of benzodiazepines. I'm calling them A/E, A standing for adverse and E standing for effects, adverse effects. And in the first place, I'm saying that they are safer and they have got a better therapeutic index as compared to barbiturates. Because I'm talking about the adverse effect, I need to know what kind of a drug I'm dealing with. Is it better? Is it going to be safer? Yeah, it's going to be safer as compared to the barbiturates. But still, they will produce adverse effects. And what are these adverse effects? As far as the central nervous system is concerned, they produce dizziness, vertigo, ataxia, disorientation, amnesia, which we already discussed, and hangovers. Because the central nervous system is depressed, it's going to impair the psychomotor skills, and the driving and the operation of the machine is going to be in trouble. They produce hypertension and respiratory depression, and very importantly, sometimes sudden apnea can get precipitated. They lead to tolerance, and they produce dependence, which is of both the types, psychological, that's psychic dependence, as well as physical dependence. And lastly, always try to remember the adverse effect, and at the end of the adverse effect, think about the acute overdose toxicity. So the last adverse effect I mentioned is the acute overdose. And how to manage the acute overdose? The answer is flumazenil. Flumazenil is competitive antagonist at the benzodiazepine receptor, and fortunately is also useful to treat benzodiazepine as well as non-benzodiazepine overdose. So let it be benzodiazepine or non-benzodiazepine, the answer is same, and that's flumazenil. The dose is 0.2 milligrams per minute by intravenous route, and fortunately it produces a prompt action. It's not selective, it's not specific just for benzodiazepines, it acts on benzodiazepines as well as non-benzodiazepines. These are the sedative hypnotics, so what are going to be the drug interactions? These are producing CNS depression, and this is why if you give benzodiazepines with other drugs which are going to produce CNS depression, naturally there is going to be an addition of the effect, what's called additive effect, and this additive effect is not going to be good. This additive effect is going to lead to too much of central nervous system depression, which could be dangerous. And you have other CNS depressants, just for your reminder, alcohol, barbiturates, classical antihistamines do produce CNS depression, and the opioid group of drugs. The second type of interaction happens when the patient is receiving a benzodiazepine and he is receiving another drug which is an inhibitor of the hepatic microsomal enzymes or the CYP3A4 system especially. And these other inhibitors are going to decrease the metabolism, the breakdown of the benzodiazepines, and the effect of the benzodiazepines will be in excess. We need to remember if the patient is receiving any other drugs and whether the patient is receiving cytochrome P450 enzyme system inhibitors like an azole antifungal, ketoconazole, a macrolide antibiotic like erythromycin, an H2 blocker like cimetidine, or an antituberculosis agent like INH. Now, if you want to treat a patient for his complaint of insomnia, I should choose a short-acting benzodiazepine or a long-acting benzodiazepine. It's very interesting. Try to concentrate and understand. If I use a short-acting benzodiazepine, then it's going to finish the action early. So by the time I wake up the next morning, I am likely to be fresh and the action will be over. So I'm going to have minimal hangovers. If I use a short-acting agent, the advantage is during the day, I'm going to be fresh. So you will think, let me use short-acting benzodiazepines. At this particular stage, your thought is right. But think of this patient. This patient suffers from insomnia. It's not going to be a short-term illness, and the patient might be needing the treatment for a few months or so. And the patient will gradually get used to the benzodiazepines. You're giving it every day, say for a period of 2 or 3 months. And when you want to stop it, when you want to finish and complete the treatment and tell the patient from tomorrow, don't take a benzodiazepine, what's going to happen? Yes, because they produce drug dependence, the patient is going to go into the withdrawal symptoms. And because this drug was short-acting, there's no much accumulation of the drug inside the tissues, no much drug is present in the blood. Because it is short-acting, you're going to get rebound symptoms after stoppage. And the rebound symptoms will be more severe because the benzodiazepine you chose was a short-acting benzodiazepine. So, if you use a short-acting benzodiazepine, hangover will be minimal, but the rebound symptoms will be more severe. Let's go to the other situation. Oh, this is happening with shorter acting. So why not go for longer acting benzodiazepines? So I'll use longer acting benzodiazepines. I'll use them for a period of few months. And when I stop it, what's going to happen is, because it is longer acting, it's going to maintain a certain concentration inside the body. So when I try to stop it abruptly, I'm not going to get a severe withdrawal symptom. Because there is some level of the benzodiazepine, because all these months is acting and it's a long acting benzodiazepines. So does this seem to be the right answer? That if you want to treat insomnia, use a longer acting agent because the effect of the withdrawal symptom, the rebound, is going to be less? Yes, we are halfway through. Another thing is going to happen, that because you are using a longer acting benzodiazepine, your patient is taking it at night. Even if the patient wakes up tomorrow morning, the patient is not going to be fresh. The patient is going to have hangover. So it's funny. So if you use a longer acting benzodiazepine, the duration of action is long. So hangover is very common and profound. Whole of the day the patient is going to feel drowsy. But these agents are good in a way that if you treat with these agents for a long time and when you want to stop it, you can stop it comparatively easily. And the rebound phenomena after withdrawal are less marked. I'm not going to give you a definitive answer taking one side. Use a shorter acting agent or use a longer acting agent. You have to think of the situation, you have to think of the complaints of the patient and then make a right decision. I hope at the end of the chapter probably you yourself will be able to make the decision. We come to the uses of benzodiazepines. Let's make the use of benzodiazepines are extremely useful for many conditions. Number one is anxiety states, because we saw they also have a selective anxiolytic action irrespective of the general central nervous system depression. So number one is anxiety states, that includes the phobic states, the phobias and the panic attacks. Next one, they can be given for daytime sedation. Next one, you can use benzodiazepines for the management of insomnia and for the management of night terrors. This is because of their hypnotic effect. I'm separating the next group of therapeutic uses because the modality of the action changes. They are sedative hypnotics and they are preferred as pre-anesthetic medication to produce sedation in a patient who is being taken for surgery. So give it before anesthesia to calm down the patient, to decrease the anxiety. So that's pre-anesthetic medication. Some of the benzodiazepines are also used as intravenous anesthetics, and they can produce anesthesia when they are given by intravenous route of administration in relevant doses. The next important use in clinical practice is the conscious sedation, in which the patient is depressed as far as the central nervous system is concerned. There is decreased arousal in this patient, but still the patient is not unconscious. So I'm calling it conscious sedation. Midazolam and diazepam, they are used for this purpose when you want to carry out a surgery and you don't want to have the risk of general anesthesia. It's a small procedure, it's a short procedure, and you can do it under local anesthesia. But along with local anesthesia, you can supplement it with benzodiazepines, and we call this as conscious sedation. So also, when the patient comes out of general anesthesia, the patient needs sedation, and that's called post-operative sedation. So all these three conditions which I'm describing are related to the operative procedures: pre-anesthetic, during the short procedure as intravenous anesthetic, for some procedures as conscious sedation, and for post-operative sedation. There are various procedures in which benzodiazepines have got extreme value, and I'm taking some names of the procedures like electroversion, catheterization, the cardiac procedures, electroconvulsive therapy, endoscopies, obstetric procedures, and many other minor procedures. You can think of using the benzodiazepines. The next important use of benzodiazepines is in those patients. They don't have the disease of anxiety. They don't have a specific illness as insomnia. But these are a group of patients who were receiving some drug of abuse, who were using some drug of abuse over a long period of time. So they were the addicts who were using the drug over a long period of time, and now they are stopping it. Or they are undergoing treatment for addiction, and we are going to withdraw the addicting substance. When you try to withdraw the addicting substance, one of the most common symptoms the patient is going to get during the withdrawal symptoms is anxiety, a very severe anxiety and restlessness. The second important symptom this patient is going to have is a lack of sleep, and that's insomnia. So I'm coming to alcohol withdrawal state. Not only alcohol withdrawal state, but many other drug withdrawal states. You can use benzodiazepines, and they have got a great value to take care of the patient when he is suffering from these two symptoms. That's anxiety and insomnia will be taken care of when the patient is going into the withdrawal symptoms. The third important thing could happen in few cases is during the stage of withdrawal, the patient could get seizures, the patient could get convulsions. And I want you to remember that benzodiazepines have got an anticonvulsant effect. And this is why benzodiazepines become of great value. So they are used in the management of addiction, in the alcohol withdrawal states, and the drug withdrawal state. Next use is following from the anticonvulsant action, and we can use benzodiazepines in condition of status epilepticus when a patient is getting a severe attack of epilepsy, number one. Secondly, we are going to use them in children to treat the febrile convulsions, one of the most common cause of convulsions in children. And the third condition is an infectious disease called tetanus, and this also you could get convulsions. Are the benzodiazepines asking the cause of convulsion? No, they have got an anticonvulsant effect. So when the patient is coming in emergency room, you don't know what's the diagnosis, what's the cause of this convulsion. You just want to stop the convulsion. That's your purpose at that particular point in time, and you can safely rely on benzodiazepines. Lorazepam and diazepam are the two agents. Look at the slide, I made them blue to make you remember. They are used by intravenous route of administration. Once upon a time, diazepam was the drug of choice. Nowadays, I am writing the name of lorazepam before diazepam. You need to remember this, lorazepam. And if you saw this particular presentation with quite interest, then you might notice that I had shown you the classification of benzodiazepines based on their half-life. And in the middle, there was intermediate acting up to 40 hours, and there was lorazepam. And I had made it blue to make you remember. The purpose was lorazepam has got a slow redistribution outside the central nervous system. So its half-life appears to be less, but when you give lorazepam, in reality, it remains in the brain for a longer period of time. It comes out of the brain slowly. That's called slow redistribution. And this is why lorazepam can give a prolonged effect, a longer effect. And that's why in place of diazepam, I'm writing lorazepam first and then of course diazepam to stop convulsions due to any cause, including status epilepticus, febrile convulsions, tetanus, or any other poisoning or overdose which might have produced convulsion. It's just an anticonvulsant effect. As I said already in the actions, benzodiazepines are centrally acting muscle relaxants and they can be used in many conditions of spasticity. Some forms of epilepsy, benzodiazepines can be used. They are anti-seizure drugs. An important drug is clonazepam and it is useful in various types of epilepsy. We also said that they have got a capacity to prevent the stress ulcers by decreasing the nocturnal gastric acid secretion. So you can think of using benzodiazepines with drugs like analgesics, non-steroidal anti-inflammatory drugs, spasmolytics, or along with the anti-ulcer agents. Benzodiazepines are also used for evaluation of anti-ulcer drugs because they have got a capacity to prevent the stress ulcers. So these were the therapeutic uses of benzodiazepines.